دكتور محمود، دكتور سمير، دكتور طارق، ممكن يطلعوا. شكرا. احنا عندنا احنا اول مره في الكارديو ميتابوليك الاينس هيبقى عندنا every time مره هيبقى عندنا فورين سبيكرز لغايه ما يبقى فيزيكال. ممكن today we have احنا السيشن دي القادمه عباره على الكوفيد COVID-19 and its indirect impacts. I think, hello, Dr. Salim. Now it's an honor for me to introduce Dr. Salim Virani. Dr. Salim Virani is from Baylor College of Physicians, Houston, Texas. It's a very famous institute. He's a staff cardiologist, Michael DeBakey Veteran Affairs Medical Center. He's a cardiovascular disease fellowship program director in Baylor College of Medicine. He's a co-director of VA Advanced Fellowship Program in Health Service Research and Development, Michael DeBakey Veterans Affairs Medical Centers. Dr. Salim, my name is Mohammed Sobhi, Professor of Cardiology, Alexandria University, and the Steering Committee of ECC Governors in Middle East and Africa. And I have with me also Professor Khalifa, Professor of Diabetologist, Professor Nabil Kafraoui, Diabetologist, Professor Samir Naim, Professor of Endocrinology, and two eminent cardiologists, Professor Mahmoud Hassanein is a fellowship responsible for the editorial board of Egyptian Society of Cardiology Journal, and is past president of Heart Failure Working Group, Egyptian Society of Cardiology, and Professor Tariq Zawawi, Professor of Cardiology University. I have a lot of internists, cardiologists, GP, looking for you for your important lecture about the COVID-19 implication in cardiometabolic disorders, and this will be followed by discussion. Dr. Salim, the floor is yours.
Thank you very much. Assalamu alaikum.
Can you raise the sound, please? We can't hear you.
Yes.
Well.
Is it better now?
Yes, okay, go ahead.
Perfect. Good evening. And really, the organizers for this opportunity, all the chairpersons for the conference. What I thought I would talk about in the next 25 minutes or so is to talk about the indirect impact of COVID-19. We all know that COVID-19 affects the cardiometabolic symptom directly, but what I am more interested in, which I think is extremely important for us, is to understand what are some of the implications over the years that we need to keep an eye on. Again, these are my sources of research support, none of which are in direct conflict with the talk today. So these are the things that I will talk about. What are the outcomes among patients with cardiovascular disease who contract COVID-19? What is the direct impact of COVID-19 on the cardiovascular system? Again, that is well known to the audience. I am not going to spend too much time. I'm going to spend quite a bit of time talking about indirect cardiometabolic impacts of COVID-19 when patients defer care, lack of physical activity, what are things related to diet, substance use, and poor mental health, because they will become the long-term determinants of cardiometabolic disorders in the next few years to come. And then what are some of the challenges that we will face in terms of healthcare systems? And then what can we do now to avoid these long-term impacts of COVID-19 in our population? Of course, this is no news to this particular group. We all know that hospitalizations are 6 times higher and death is 12 times higher in COVID-19 patients who have either lung disease, diabetes, or any form of cardiovascular disease. These patients are at a much higher risk of hospitalizations as well as death from COVID-19. Now, we know that COVID-19 affects pretty much any organ system, just like any viral infection. But we know that as far as cardiovascular system is concerned, even for that, we have a lot of data now. Even the ARDS, the adult respiratory distress syndrome that people develop because of COVID-19, of course leads to a lower amount of oxygen available to the heart tissue, which we know per gram of tissue uses a lot of oxygen. So that in itself can lead to myocardial injury. And we see quite a bit of patients who have troponins that are positive. We know that there is sepsis-related myocardial depression that happens. We have all seen cases of myocarditis with COVID-19, cardiomyopathy. We have seen various arrhythmias associated with it. And those of you who've taken care of COVID-19 patients would also know that more recently we have come to realize that having COVID-19 also increases a patient's risk of having venous thromboembolism. So DVTs and PEs, deep venous thrombosis, pulmonary embolism. I'm sure you all have seen that in your patients with COVID-19. And we know that a lot of these direct impacts, it goes into two major phases. The initial phase is the damage related to the virus itself, but then a week to 10 days later, we have this cytokine storm that affects pretty much any organ system that we have. Now, that was the direct impact of COVID-19 on cardiovascular system. I think what I am more interested in, which I think will be much more important for the next few years to come, is to talk about indirect impact of COVID-19 on cardiometabolic health as well as cardiovascular system. So let's talk about some of this stuff. This is some of the data that came in from US early on, saying that as the number of COVID-19 infections went up, what you will notice is that the hospitalizations for acute MI went down when you compare for 2020 and compare them to 2019. So hospitalizations for COVID-19 going up, but hospitalizations for heart attacks going down. Now that was very interesting. We were just not seeing patients with COVID-19 in our hospitals. This was in the month of May, March, April, May, when we had COVID-19 in US, when we were taking care of those patients. And really, there were these articles that came up that because of COVID-19, heart disease and stroke patients have gone missing. We just did not have very many patients coming to the hospital. And then we knew that in the 10 weeks following the COVID-19 national emergency, which in US was in the first week of March, the visits to emergency departments for heart attacks, strokes, or diabetes went down anywhere from 10 to 25%. So a lot of these patients were not coming to the hospital because of the fear that if they came to the hospital, they will catch COVID-19 infection. What we also found out in one of these large studies that was done was that if we look at various parts of the world, cardiovascular procedure volumes went down as well. If we look at, just in the month of March, it went down by 42%. But if you look at the month of April, 64% reduction in cardiovascular procedures. Now, of course, some of those were procedures that were elective, but quite a few urgent procedures also went down. And if you look at it, it was not just a US and Canada issue. This was seen in Western Europe. This was seen in Far East. This was seen in Latin America. This was seen in Middle East and Southeast Asia and Pacific, Eastern Europe and Africa. Everywhere in the world, cardiovascular disease-related procedures went down, and they went down quite appreciably. So this one study came out that really caught our eye. And what it shows is that when we look at just the US, and I believe it's the same pattern that we will see in many other countries, is that if you look at from March till June, deaths related to heart disease went up. When we look at deaths related to hypertensive diseases, it went up in US as well. So what was happening? Patients were basically staying home, they were deferring care, and therefore a lot of these heart attacks and strokes were leading to excess mortality. You see the numbers for 2019 here. There's definitely a spike in deaths related to ischemic heart disease in 2020, as well as hypertensive disorders. If you look at where this was happening, a lot of this was happening in the state of New York and the city of New York, where most of the COVID-19 infections occurred. In fact, if you look at it in Europe, when you look at admissions related to either heart attack or heart failure, what you will notice is that there were two waves, right? This is the first wave where the admissions went down. And then again in November, when Europe was going through the second wave of COVID-19, the admission rates went down for acute MI as well as heart failure. When you compare them to 2019, they are much, much lower in the first wave as well as the second wave. This is something that we recently looked at. As the number of COVID-19 related deaths went up, guess what we noticed? We noticed that deaths related to cardiovascular disease went up, and deaths related to diabetes also went up. When you compare them to what the axis is, this is the average. Anything above the baseline here is excess number of deaths. And what you see here is that deaths due to cardiovascular disease as well as deaths due to diabetes went up. And this is interesting because a lot of this is related to our patients not seeking care. So what we found in US was, and this is directly from CDC, that 4 in 10 patients in US deferred care. They just did not get the care that they wanted to. And the other important thing is that a lot of this deferment of care occurred in patients who had a lot of comorbidities. So the patients who needed the most care were actually deferring the care. So the ones who really need to be seen by physicians were the ones who were not showing up in clinics or the emergency rooms. So that's one aspect of the indirect impact of COVID-19 I wanted to talk to you about. And we know that this has led to a lot of increase in mortality in US, and I believe this is probably the case in very many other countries. The other aspect of this, which I think will be very important for the group here, is the reduction in physical activity that happened because of COVID-19. This is worldwide data from Fitbit. Of course, that's the gadget that most of us use, but you remember, not everybody uses Fitbit. So these are people who are very, very physically active. Even when we look at this group, which of course is a biased group, look at what happened in the first week after the declaration of COVID-19 pandemic. All across the world, the physical activity went down anywhere from 10 to 15 to 20%. If you look at various countries, look at the number of steps that have gone down. If you look at Japan, if you look at China, look at how much it went down. If you look at Italy, you look at Hong Kong, if you look at Great Britain, or you look at US, in all of these countries, the people cut down on their physical activity. And I'm sure if you look at Egypt, you will probably find the same patterns, that people came down on their physical activity. They stopped walking. If you look at various cities within the United States, you will see the same trend. As you went farther and farther out, the physical activity that people had went down a lot. So people were cutting down on their physical activity. And this is again data from various countries that was published in May. And you will notice that there was a good reduction in physical activity in all of the countries related to COVID-19. So again, we talked about patients not coming to get care at the hospitals. We talked about physical activity going down. Let's talk about diet. This is a very large data of survey that was performed related to dietary habits in US. And what we'll find is people were increasing their consumption of candies, sweet cakes, and at the same time, chips and other snacks were also increasing as far as consumption of these is concerned. So you can imagine that if we draw out over the next 3 to 5 years, it's going to be very difficult for people to now go back to healthy lifestyle. And that we believe will lead to a much higher risk of cardiovascular disease mortality in the next few years to come. So we talked about deferred care. We talked about lack of physical activity. We talked about poor diet. What about mental health? So in US, if you look at some major surveys, about 1 in 10 individuals, about 10 to 11%, have expressed that they have anxiety or depression. But guess what happened when we had COVID-19? These rates went up almost fourfold. So 4 out of 10 adults have symptoms of anxiety and depression. And why is that important? It's important because if people have mental health issues, they are not going to be able to be physically active, have a good diet, or take the medications that they prescribe. Of course, we've been talking about a lot of these medications that work in AFib, in heart failure with preserved ejection fraction. But if patients have anxiety and depression, they are not going to be taking those medications. And we notice that this is a case for essential workers. I'm sure in Egypt, we have quite a few essential workers as well who have to go to work every day. They are the ones who have more anxiety and depression. And look at substance abuse. That has gone up as well as the number of people saying that they feel like that they want to die, they want to commit suicide because of the COVID-19 pandemic. So it has also taken a mental health toll on everybody. So I talked about the deferred care, we talked about diet, we talked about physical activity, we talked about the toll that COVID-19 has taken on mental health. But what are the challenges for the healthcare system? What is it that we can learn from influenza that we can use towards the use of COVID-19 pandemic? Well, I don't know about Egypt, but in US, only 50% of the patients who have cardiovascular disease receive a COVID-19 vaccine for influenza, for flu. Now that is a problem. And if you look at the US map here, look at how much variation we have depending on where a person is living in terms of receiving the influenza shot. We hope that this will not be the case with COVID-19 because that will be a problem. The other thing that US did as a country was that we started telehealth, where physicians and patients can talk on internet or a video call or a phone call. But even when you look at the availability of internet in US, it's low. But when you look at the patients who need it the most, patients with cardiovascular disease, only 2/3 of them have access to internet. And even that access varies whether you're looking at a Black patient or a white patient, a Hispanic or a white patient, and look at how much it varies by geography. So we can say, yes, telehealth is good, but even for telehealth, we are going to face some challenges. And this is patients with diabetes and hypertension. Since we're talking about cardiometabolic disorders, the same story basically is seen in patients with diabetes and hypertension. Only 72% of those with hypertension or 65% of those with diabetes have internet access. And again, the same way as we saw with patients with ASCVD, there is a huge geographic variation when it comes to the availability of internet. So taking care of these patients with cardiometabolic disorders is going to remain a challenge. So, back in the March of last year, we published this piece in Circulation that, okay, if you look at how many curves or how many mortality curves are we going to have because of COVID-19, we could think of at least 5 curves. First was acute COVID-19 infection. We lost a lot of people, I'm sure in Egypt as well as we did in US and in other countries of the world. A lot of that mortality and morbidity was related to acute COVID-19 infection. I showed you some data then that delays in care and lack of guideline-directed care has led to a lot of deaths as well. What we are seeing now is this third iterative COVID-19 curve. Right now, we are seeing these curves come over and over again every few months and leading to a lot of deaths related to that. And then what we're going to see over the next few years is what we are talking about now, neglected care, people not taking care of themselves because of diet, physical activity, people are getting depressed, and that is going to take its toll. And we believe the long-term impact, which is going to be the curve number 5 here, is going to be related to the mental health related disorders because of COVID-19. So what is it that we can do right now? So the take home messages are that patients with cardiometabolic disorders, of course, are at increased risk of complications from COVID-19, but more importantly, indirect effects of COVID-19 on cardiometabolic have been and continue to be more detrimental. We will probably lose more lives from these indirect effects of COVID-19 than the direct number of deaths we had because of COVID-19. And these may cause more loss of life. So, what can we do now? What should we do to counsel our patients? I think we should let our patients know to stay active, eat a healthy diet, and maintain a healthy lifestyle. Avoid alcohol and other illicit drugs, which goes up anytime we have a pandemic. Again, physical distancing does not mean that we have to be socially disconnected. People should remain connected with their families and friends. Do not defer care, especially if it's emergency as well as outpatient care. We have to remain connected with our clinicians, with our healthcare providers, staying adherent to good lifestyle as well as prescribed medications. And then everyone around us, especially those who are vulnerable, those who have cardiometabolic disorders, heart disease, stroke, diabetes, we should encourage them to get vaccinated as soon as the COVID-19 vaccine becomes available, because we know that our patients with cardiometabolic disorders will derive a lot of benefit. With that, I thank you for your time. And I have one message for you, which is a proverb from Tibet. The secret to living well and living longer is to eat half, walk double, laugh triple, and love without measure. So again, with that, I'll stop, and I thank you for the opportunity to talk about this.
Love without measure is difficult. So thank you very much, Salim. I have two questions for you. Number one, regarding at start of the COVID, is suggestion called the high risk population, and hypertension is one. The second, diabetes, then COPD, which is strange that to found that the mortality is high of a patient with hypertension, diabetes, COVID, rather than those with COPD. This is the first question. The second, that I face the problem now in examination of the patient, and now it's starting to have what's known as virtual visits by telemedicine. Do you think this should be a future for the treatment, or we come back physical within 1 year after vaccination?
Those are wonderful questions. So going back to your first question, it's very interesting with diabetes and hypertension having a much higher mortality. And is it because of something to do with the ACE receptor that COVID-19 virus uses to enter the pneumocytes? And we know those are the same receptors that we use which is present on our cardiac myocytes, on endothelium as well. So is there an interaction related to cardiovascular disorders because of that ACE receptor? I don't think we have the answer to that, but those would be some of the mechanisms. Now, going to your second question about telehealth, I do believe that for the next few months or 6 months to 9 months, we will definitely still have a lot of telehealth, but definitely there is a role for physical visit by the patients, right? I was very intently listening to the lectures on heart failure with preserved ejection fraction and the other case that was just discussed. In some cases, we need our patients to be physically present. So I think what we will see, if I am reading the situation correctly, is two things. One is that we will find that there are some patients who need to be seen in person. So there's going to be a hybrid model. Patients who have urgent issues whereby they need to be examined to assess their fluid status, or they need to be examined with a stethoscope or something. In those cases, patients will probably have to come in, but a lot of their visits will probably be done virtually. So that's one thing that I am seeing. The other thing that will happen here is that we will have to improve the technology we have for telehealth visit, because just calling up a patient on the phone is probably not the same as a patient doing a live video visit with a clinician. So I think the technology will have to improve, and we'll have to make sure that the patients have access to that technology. So I think those are the two big trends that we will see. And then I am pretty sure that there will be a lot of science that will come out that whether the visits we have using telehealth models, are they as good as live visit in a clinic by a patient? So I think those are some of the ways I would respond to this very important question that you asked.
Thank you very much, Professor Salim. It's me, I'm Asad. I'm an endocrinologist, and we are sharing ideas with a cardiologist. A great pleasure to have you among us. Actually, you brought me back 35 years ago when I was at Baylor doing my PhD thesis with my mentor, Professor Glenn Cunningham. I don't know, he's from the Department of Endocrinology on Fannin Street. I remember the name of the street. Professor Mahmoud was with us as well. My question is about steroids, because here in Egypt, the pulmonologists are giving steroids almost to many patients, and this is bad for the heart and for diabetes, of course. So what's the practice in the USA, the use of steroids for COVID? Thank you.
Wonderful question, and great to hear from somebody who was at Baylor, who knows Dr. Cunningham and the Fannin Street. So thank you for bringing, sharing those memories with us. As far as the steroids are concerned, of course, it's a short-term steroids that are used. In US right now, steroids are mostly used only in patients who are hospitalized. As you know from the data that's been available for COVID-19, steroids only work in severe disease. There's not really very good data that it works in mild forms of the disease. So we in US are mostly not using steroids for outpatient management of COVID-19. We are reserving it for patients who are very sick and in the hospital, and we're using very short-term doses of steroids. So we hope that with those short bolus therapy of steroids, it will not lead to long-term impact as far as the endocrine system or the cardiovascular system is concerned. So that's where we are right now in US. Again, very short-term use, mostly in patients who are inpatient in the hospital and not using them in outpatients per se. I don't know if the practice is different in Egypt. In Egypt, are patients being prescribed steroids in outpatient?
It's malpractice, really. It's not. Well, a similar question about the use of oral anticoagulants in COVID-19 patients. What is the policy you adopted in the United States?
Sorry, can you repeat the question? I could not hear very well.
The use of oral anticoagulation in general in patients with COVID-19. What's the policy in the United States?
Again, wonderful question. So what we are doing is that anybody who is admitted to the hospital, we definitely use an anticoagulant on them in the prophylactic doses that we would do in our patients who had orthopedic surgery or other high-risk conditions. So we would either use enoxaparin or heparin sub-Q in those patients to prevent DVTs and PEs, which we have seen quite a few, and I'm sure you are seeing some as well. So during hospitalization, we need to make sure that we do not have any episodes of DVTs and PEs, which are very common, and even not just the DVT PEs, but there is a big science, as you're aware of, that these microthrombi can form in the pulmonary circulation as well and exacerbate the ARDS that's associated with COVID-19. So for those two reasons, inpatient, we use quite a bit of that. And then once patients are discharged, if they make full recovery and they go home, then I think it's very variable. Some people will say that if it's a patient who does not have a lot of comorbidities, they will just ask them to stay active. But if it's a very high-risk patient, some may use an anticoagulant, a NOAC, a novel anticoagulant, for about 6 weeks to 3 months before the patient is fully active once they get home. So that is what we are doing. But in the hospital, we are very, very aggressive with COVID-19 patients in the use of anticoagulants.
Thank you, Professor Salim, for your nice talk. According to the data you showed us today regarding the change in exercise and dietary patterns together with an anxiety. Do you think in the next few years we are going to see increased incidence of type 2 diabetes?
That's a wonderful question. I'm glad you're already thinking about it, because that is the worry that we have, right? Because if you look at the last 10 years with the WHO's declaration about NCDs and all that, we were making slow progress. And now, because of COVID-19, of course, all of those things have been pushed down again. I personally worry a lot that in the next few years, because of these physical activity patterns and dietary patterns, I do believe it's very difficult if you have not been walking for 1 year to then go back and start your walking again. So I do believe that because of that and the diet and the mental health related issues, I think our lifestyle will suffer long term. And I do worry that actually the risk of diabetes will probably go up. And I think those are going to be some very fascinating studies. But importantly, what can we do now to prevent that from happening, I think will be very, very important for all of us, whether we live in US, whether we live in Egypt, whether we live in India, all of these places. I think diabetes is becoming a major, major issue. And I think I do worry that we will have those issues going forward. And as you saw, some of the data I showed you, that even deaths from diabetes went up actually last year in US at least. It was way more than what was expected based on the last 8 years. So there is definitely this thing. It's not just new cases of diabetes. I think diabetes control amongst those who already have diabetes will probably also worsen. So I'm glad that you asked this question, because I do worry about it.
Professor Salim, thanks for this elegant talk as usual. And I want to ask, in this cardiometabolic alliance, now we will discuss a case of the post-COVID and acute coronary syndrome. And I want to ask you about the drug-drug interaction between the anticoagulants and the antiviral drugs in the post-COVID, and there's a contraindication or drug interaction between the anticoagulants for COVID and the anticoagulants for the acute coronary syndrome.
So that's a wonderful question. Right now, we have not seen any major drug-drug interaction. Of course, if somebody had ACS, my biggest worry would be that if you're going to be using dual antiplatelet therapy with aspirin and clopidogrel or any of the other antiplatelets, then using an anticoagulant will increase the risk of bleeding, especially for a patient who's an older patient who has a lot of comorbidities. So not as much drug-drug interaction in ACS patients, but I would worry about dual antiplatelets plus an anticoagulant if one were to use it in the face of COVID. That is my biggest worry.
Thank you, Professor Salim, for this excellent presentation. My question about the role of ACE2 for the COVID infection, there is a lot of debate. But my question about, what's your comment about the use of recombinant ACE2 as a therapeutic approach, experimental therapeutic approach?
I mean, it's a fascinating field. As you know, I mean, we have published quite a bit on ACE2. There has been ACE2 polymorphisms are associated with increased mortality in patients with cardiovascular disease. There are some polymorphisms that are associated with lower mortality. But first of all, use of ACE inhibitors seems to be safe. Now, in terms of recombinant ACE2, that's where the debate is. A lot of people are using it, but we have not seen very convincing data that using recombinant ACE2 will decrease the severity of COVID-19 infection in large randomized trials. Of course, there are some pockets of small data that is available. So I think we are all very patiently waiting for large data sets to show that the use of recombinant ACE2 will be beneficial in patients who have COVID-19. So I think we probably need to wait for long-term studies before it's widely prescribed.
Dr. Salim, before we close, what do you see the future after vaccination with the new era after COVID, so the near normal life? Is it, we still have, because we don't have data except 6 months. So do you think that we have a booster dose, we have tablets after, We have to continue to see what's the result after 1 year. What will be the future in USA? Because we don't have a future. Actually, the ECC will be virtual in May. The TCT will be virtual. European Society will be virtual. Still in Egypt, we do now a lot of virtual, but we have hybrid. That's why this is an example of hybrid. So what do you think of the future in normal life and the health of the people?
I think I wish I knew the answer, but I'm glad that at least you're doing a hybrid. Unfortunately, we could not do ACC hybrid or in person, so ACC has gone fully virtual, as you know. But you know, in US right now, I think we're up to about 150 million vaccination doses that we have given. The biggest issue remains that we still have good 20-25% of the population that has vaccine hesitancy. And then these variants now that are emerging, right? How responsive will they be to the vaccine? And then how long does the immunity last? You know, Pfizer just presented data yesterday that at least up to 6 months, it does look like immunity is preserved after COVID-19 vaccination. Now, I don't think I have a crystal ball as to how things will look like. I do think, though, that COVID-19 is not going to go away anytime soon. We will still have these periodic things. Well, in the month of, you know, in winter months, you wear masks. Outside of that, you may be able to take your mask off if you're fully vaccinated. And there might be some boosters as well that are given every year based on, you know, the variants that are out there, as well as they will boost your immunity. I don't know if I have the answer, but I believe that's where most people are thinking things are going to go, that we will probably have an annual booster, just like we give flu shot every year. And at the same time, masks are not going to go away fully. We'll probably be wearing them, not as much as we are now. Hopefully there will be more places where one can go and meet people in person. Like I would love to come to Egypt and meet all the colleagues. I have a lot of history there that I would like to see. But of course, that I do believe will happen sometime soon once we are able to vaccinate a lot of people. The other issue that I feel, and I think I have to say this, is that we are lucky in US that we have this vaccine. But I think a lot of us feel the pain that for a lot of our brothers and sisters in other countries, vaccines are not available. And I think if we need to really eradicate this disease or get anywhere close to it, we have to find a solution that the vaccines are made available to every country in the world. And I think that's where our struggle will be as humanity. And I think that's an important
Okay, thank you. Before we close also, I'd like to congratulate the first Indian lady today, inaugurated as the president of ECC, my friend, Deputy. She's a friend to me and most of the cardiologists in Egypt, and will join with me with the next ECC in Cairo in the beginning of October as ECC in international. And also this is the first lady to be after another lady, which is Atem Poupé, my friend, which was a president. As you know, there's two ladies, one president, the second president, and also Indian at the first. You know, I like the Indian. The first Indian man who taught me do the coronary angiogram, 1984, Muhammad Farid Kaja in Henry Ford Institute, 1984. So the Indian is most French, have a lot of friendship all over the world. So I'd like to thank you very, very much for this wonderful lecture. I think all the audience here like this was looking for you for questions, our questions for you, the answer. And I hope to see you physically next year. Thank you very, very much. Bye-bye.
Thank you very much.
Next section هتاخد بريك. هناخد ربع ساعة بريك بالظبط. حرك رجليك بس تعالى.